Ancient writings by the Egyptians and Greeks describe theories of respiration. In the Old Testament, there is a mention of Prophet Elisha inducing pressure breathing from his mouth into the mouth of a child who is dying. Hippocrates wrote the first description of endotracheal intubation in his book Treatise on Air, where he described one should introduce a cannula into the trachea along the jawbone so that air can be drawn into the lungs. Since this time, there have been many advocates and pioneers of positive pressure ventilation. Paracelsus, born Philip von Hohenheim, used fire bellows connected to a tube inserted into a patient's mouth as a device for assisted ventilation. This was the first study which credited him with the first form of mechanical ventilation. Vesalius, in 1543, performed ventilation through a tracheostomy in a pig and artificial respiration by a hollow tube of a reed or cane. Hooke, in 1667, used bellows through a tracheostomy in a dog. It was in 1744 that Fothergill reported a successful case of mouth-to-mouth resuscitation. And Hunter in 1775 developed double bellows for resuscitation, one for blowing air in and the other for drawing bad air out. Since that time, the state of resuscitation has basically remained unchanged for about 150 years. Despite the promises of positive pressure ventilation, the inability to accurately control pressure led to its disuse. Led by such critics such as Leroy d'Etoile, who recognized that a pneumothorax may be due to positive pressure ventilation, and the Royal Humane Society, who abandoned intubation and bellows resuscitation. Ultimately, positive pressure ventilation was banned in the medical practice in the mid-1800s. Following its decline, negative pressure ventilation soon replaced positive pressure ventilation. Negative pressure ventilation was the first form of non-invasive mechanical ventilation and was accomplished through devices known as iron lungs or iron thoraxes. Negative pressure ventilation was primarily used during the polio epidemic and helped to increase the survival rate of patients suffering from respiratory paralysis secondary to polio. Negative pressure ventilation devices evolved throughout the 17th and 18th centuries. Here we see a range of pressure devices from 1864, where the Jones body box was introduced, through 1931 and the Emerson iron lung. However, these devices were bulky in size and required a significant amount of space for use and limited the clinician's access to the patient. Positive pressure ventilation returns. A return to positive pressure ventilation occurred initially in the operative suites of the early 1900s. It showed greater success over negative ventilation during the polio epidemic in Scandinavia and the United States in the early 1950s. In 1952 in Copenhagen, a patient with polio and respiratory paralysis was supported by manually forcing 50% oxygen through a tracheostomy and had an improved outcome, leading to the return of positive pressure ventilation. However, this intervention required the continuous activity of hundreds of medical students recruited from the universities. The overwhelming manpower needed, coupled with a decrease in mortality rate from 80% to 25%, led to the adaptation of positive pressure machines used in the operating room for use in the ICU. In addition, a clustering of patients from the polio epidemic led to the development of the first modern intensive care units. It wasn't until the 20th century that the first positive pressure ventilator was manufactured. In 1907, Heinrich Draeger developed the pulmotor. The pulmotor was a positive pressure ventilator which used a modified clockwork mechanism and allowed for unchanged inspiratory and expiratory phases. It was a time-cycled ventilator. The pulmotor delivered a positive pressure breath at 25 centimeters of water and then pulled the breath back out with a negative pressure of about minus 25 centimeters of water. Although originally designed for rescue operations, the pulmotor was extensively used in hospital applications. In the mid-1900s, positive pressure ventilation with the use of an artificial airway began to replace the iron lung technology for respiratory support. The first type of ventilator was pressure cycled and graduated from use in the operating room to use in the ICU. Two ventilators most commonly used for pressure-cycled ventilation in the 1960s and 1970s were the Bird Mark 7 and the Bennett PR2. Shortly thereafter, the volume-cycled ventilator was introduced. The first fluidic volume-cycled ventilator was designed for the U.S. Army in 1964 by Barilla, and the first commercial version appeared in 1970 by Hamilton. Here we will summarize the evolution of mechanical ventilation. Although the concept of positive pressure ventilation dates back to the ancient Egyptians and Greeks, the first evidence of application was in the early 1500s. However, the inability to accurately control pressures limited its clinical application. Because of this, negative pressure ventilation became the accepted practice from the late 1800s to the mid-1900s. The use of positive pressure ventilation returned in the early 1900s, primarily in the operating rooms. In the mid-1900s, positive pressure ventilation was established in the first intensive care units. Volume-targeted ventilation was first introduced in the mid-1960s. It became a standard mode of ventilation in the 1970s. Finally, volume versus pressure-targeted ventilation is a debate which persists to this day.